International Center for Translational Digital Health. Delighted to see so many faces today. So for those of you who do not know me, I'm Neil Speak. I'm Professor of Health Mathematics at the University of Manchester, and I'm one of the co-leads of the center from Manchester, together with Ange Davids, who's the other co-director from Manchester. As you will probably all know, but I'm just going to repeat in case you don't. The International Center for Translational Digital Health is a collaboration between the universities of Toronto, Manchester, and Melbourne, focused on digital health and specifically on how we can make an impact with digital health research. So not just write nice papers, which obviously is something that we also want to do, but also we want to translate things into the real world so that patients and healthcare professionals can benefit from the work that we do. So therefore, the term translational in the title of the center. We've got three broad themes that we focus on. We call them hubs. So one is remote monitoring and virtual care, and today's seminar is in that hub. And we also have data science and AI and health policy and implementation. As I mentioned, this is the first time that we do this, so it's exciting. Every month there's going to be a seminar, each time organized by a different hub. And then we also have the time zone issue. So what we have decided is that we aim to have the seminar always at a time that works, well, definitely is within office hours of one of the three sites, hopefully two. In this case, that has happened, so Toronto and Manchester. In Melbourne at the moment, it's 1 a.m. in the morning. So I don't think there's anyone from Melbourne on the call. If there is, then please raise your hand and we give you an applause. But we are recording the webinar to make it available for colleagues, well, from all three sites, but specifically Melbourne. And this is how it's always going to be. Yeah, on future occasions, you might find that the seminar is at a time that works for you, or it might not, but the recording is always going to be available. So we've already started the recording. I hope that everyone's comfortable with that. With that, I'm going to hand over to Quinn to introduce our speakers from today. Thanks.
Thanks so much, Neil. We're very excited to be the first group that is able to present at this inaugural series. So I'm Quinn. I am the scientific director of the Center for Digital Therapeutics here in Toronto, and I'm also one of the hub co-leads with Sabine, who's on this call, and Dave, who I don't think is here right now. Our group specializes in building digital therapeutics, which is a different class of interventions, quite commonly software as a medical device for chronic disease management. And I'm really thrilled to have two of my associates, colleagues who we've been working together for a long time, speak about the work that we've been doing. And I think often when we talk about these things, it is quite tech driven. So obviously our group builds technology, and we're very interested in all the new advances that are coming out in our field. Our current obsession from our executive director is large language model. And every time he talks about it and redirects the conversation to ChatGPT, I get a chocolate. And so it is, we're really trying to keep up with everything that's happening in this space. But I think ultimately what matters to us and to our lab is that we're creating products that really can make a difference in the lives of patients and their families. And technology ultimately, certainly for me, is the means to an end. And I think the end is better health outcomes. And the end also is just like more humanity in the work that we do for patients and families to really feel like the technology is facilitating therapeutic relationships that would normally require them to come into an office to get that human touch. And so the work that Noor and Raima do, I think, really advance that notion of sort of more compassionate care using technology. So I'm really excited and delighted that they're taking some time out of their day to share their work with us. So with that, Noor and Raima, please take it away.
Thank you, Quinn, for that introduction, and Niels as well for sharing a little bit about why we're here today. I'm just going to go ahead and start sharing my screen, which hopefully works without too many glitches. Okay, can everybody see that? Does it look like the correct thing that you should be looking at? Okay, perfect. All right. So as Quinn mentioned before, we're really excited to be able to present to everybody today, and thank you all for joining us, and really just focusing on highlighting the work that our team at the Center for Digital Therapeutics does in digital health and remote patient management of chronic diseases, with a specific focus on how we embed health equity as a cornerstone across our portfolio, and focusing on that compassion that we try to integrate in all the work that we do to translate research into practice. So, oh no, I can't switch my slide. There we go. Okay. I just wanted to start off sharing this lovely picture of our team. So this is some of our team at the Center for Digital Therapeutics, and we are really honored to be able to work with such a talented and diverse group of colleagues. So I just wanted to take a moment to recognize everybody and really the collaborative work that we do across our team. And I just wanted to take a moment also to introduce ourselves. So Raima and I think we are both adventurers. We love being in nature and outside. These are pictures that we took in Lake Louise in Alberta, Canada, which, I mean, if anybody has the chance to visit the Rocky Mountains in Canada at some point in their lives, I highly recommend it if you have the opportunity to do so, because it's beautiful. So the picture on the left is at the bottom of Lake Louise, an incredibly scenic and beautiful lake. And the picture on the right is actually on top of Lake Louise. So Lake Louise is on the right side. And this was after we hiked up the mountain with a lot of difficulty and a lot of sweating, but always worth it in the end for such beautiful views. So I just wanted to give Raima a moment to introduce herself, and then I will introduce myself as well.
Hi, everyone. It's an absolute pleasure to be presenting today with Noor. So as Quinn and Noor have mentioned, my name is Raima, and I am a best friend, a sister, and daughter, and I love nature and in particular trees. In parallel to those roles, I also happen to be a registered nurse and the lead of knowledge mobilization at the center. So I'm very excited to share our work with you all today, and we'll pass it back to Noor to introduce herself.
Thank you, Raima. So I guess on a personal note, I am a sister to my 5 siblings. I'm a friend as well. I was born and grew up in a suburban town outside of Toronto, which is where my family immigrated to from Lebanon back in the 60s and 80s. And really all of these experiences and identities have very much shaped who I am and the work that I do. And who I am also continues to be shaped by the work that I do and the things that I learn along the way as well. And so we really wanted to start off with this introduction to remember and remind everybody that we are human first. And I think that really is something that we center in the work that we do, and very much relates to considerations around health equity. So I wanted to ground our presentation with kind of a definition of health equity, which I've thrown up on the slides, and health equity being that all people can reach their full potential and should not be disadvantaged in that because of any of their identities. And when we think about health inequities, I think it's important for us to recognize that inequities are systematic. So they are health disparities that are not random, but they do follow patterns. And they are avoidable because they are socially produced based on distribution of resources and opportunities, and can be avoided by action at individual, interpersonal, community, and structural levels as well. And fundamentally, they are unjust. And so when we think about health equity and why it's important for us to talk about it and to integrate it in the work that we do, I think as humans, we have a responsibility towards all of our relations, which is an Indigenous teaching that recognizes how we are connected to other people and to the physical world, and the responsibility that we have to care for those relationships. And so I think we have an ethical imperative to ensure basic human rights for everybody, and access to healthcare and good health and well-being is one of those rights. And beyond kind of the ethical considerations of health equity, I think it's also important to recognize that health inequity does result in many negative social and economic consequences at the population level. So there are really multiple driving forces for why it's important for us to talk about and think about health equity. And as I'm sure everybody knows, the field of digital health is definitely at risk of perpetuating health inequities because of the digital divide. And that can really result in widening the gap between socially advantaged and disadvantaged groups. So just to frame the digital divide, there are 3 levels. So the first level being that there are discrepancies between those who have access to technology and those who don't. So for example, many digital health interventions are disproportionately accessible to people of higher socioeconomic status. So people who can afford smartphones to be able to access programs like the Medleap program, which we'll talk about a little bit. And at the second level, for people who are able to access that technology, there are also disparities in having the opportunities to use that technology effectively. So we think about things like digital and health literacy and who has the opportunity to build those literacy skills, and also thinking about mistrust in the medical and structural systems within our communities. And for people who have the opportunities to use technology effectively, that still might not translate into the use of technology for improving outcomes in their health and well-being. So this can be related to things like competing priorities. So people who are facing housing or food insecurity might not be able to prioritize disease management, even if they are able to access these technologies and use them and have the technical skills to be able to use them. And also things like lack of inclusive design of our programs can hinder translating the access to technology and programs into improved outcomes. So I think what we want to frame our presentation around is remembering that translating research into practice includes bridging the digital divide. So today we wanted to walk through and share a few different ways that we are integrating health equity considerations and addressing the digital divide in our work. So we're going to walk through kind of 3 different case studies or portfolios that our team is working on. And all of these projects are framed around the Medleap program, which is our team's digital therapeutic that supports remote management of heart failure as well as other chronic conditions. So with that, I'm going to pass it over to Raima to walk us through the first program.
Perfect. Thank you, Noor. So I'll start us off by diving deeper into our work around the Medley Smart program with a focus on the equity consideration of designing products and services with community members. So one of the biggest challenges that the Canadian healthcare system is facing is caring for patients who have multiple chronic conditions. So as stated here, 3 out of 4 Canadians aged 65 and older have at least one chronic condition. And with an increasingly older population composing a greater proportion of the Canadian population, chronic disease management is becoming a significant challenge that needs to be addressed. And so patients living with multiple chronic conditions face several interconnected pain points in their care, the most prevalent listed here. So 1, for patients in Canada, the highest risk of readmission is during the first few weeks after patient discharge. Often patients may not receive adequate support and guidance during this critical time, which can result in complications and readmission to the hospital. Another pain point is the issue of siloed specialty care, which can lead to contradictory clinical management advice for patients. Many patients with multiple chronic conditions require care from different specialists. However, these specialists often work in isolation, leading to inconsistent and sometimes, again, contradictory advice for patients, making it difficult for patients to navigate their care effectively. As well, inadequate patient self-management support in between clinic visits is also a significant pain point, as many chronic conditions require ongoing self-care, such as medication management and monitoring of symptoms. So when patients receive limited guidance and support in between clinic visits, this can leave them feeling unsupported and result in suboptimal self-management and poorer health outcomes. And the 4th point here is that complex patients who are managing multiple chronic conditions may also lack the knowledge and confidence to perform appropriate self-care, as these patients often face complex treatment regimens and symptom management strategies that can be overwhelming. So they may require tailored education and support to understand and implement self-care strategies effectively. And last but not least, patients may experience fluctuations in their health, but due to limited communication channels and information sharing, their care team may not be aware of these changes in between those clinic appointments. So again, this can result in delayed interventions or missed opportunities for timely care interventions and changes. And so really addressing these pain points and finding solutions to improve patient care and support can lead to better health outcomes and improved quality of life for patients with multiple chronic conditions. So that leads me to this concept of a SMART clinic, where SMART stands for safe, managed, and responsive transitions. So a SMART clinic essentially has two key components. So the first is that there will be a trained nurse who will act as a single point of contact for the first few weeks or months after patients return home, and will facilitate communication between all members of the care team, including those from the discharging hospital and other providers in the patient's circle of care, like their primary care provider. The nurse would provide patient education and support care coordination throughout the chronic disease monitoring journey as the patient's health stabilizes. For our Medley SMART clinics in particular, our nurse coordinators are either registered nurses or nurse practitioners. The second component of a SMART clinic is the use of telemonitoring technology. Within our Medley SMART program, patients will use the Medley technology to record measures at home, which are related to their chronic condition. So that might be things like blood pressure, weight, blood glucose, symptoms, etc. And the nurse would be able to see all of the data collected by Medley and subsequently make informed decisions and follow up with the patient as needed. So then in addressing these pain points in the management of complex patients with multiple chronic conditions through the role of the nurse acting as that central point of contact in combination with technology-mediated self-care management and care team access to comprehensive and real-time health data, SMART clinics can be strongly positioned as one solution to targeting this growing challenge in the Canadian healthcare system. And so our team is trialing the SMART clinic concept across diverse Canadian healthcare institutions. And as a part of our research study, we are focusing on the primary questions of, one, how can SMART clinics be implemented to support the transition of complex patients from hospital to home? And we're defining complex patients here as those living with one or multiple of heart failure, hypertension, diabetes, COPD, and mental health considerations. And then our second primary research question here is, what is the effectiveness of SMART clinics on patient outcomes? So I won't go into the research in too much detail, but there will be dual evaluations. So one for the implementation evaluation, which will be a multiple case study design that evaluates implementation success, leveraging the consolidated framework for implementation research and the Proctor implementation outcomes framework. So if you could go to the next slide there. Yeah, so that's just listed out there. And then that second evaluation piece will be the effectiveness evaluation, which will consist of a pragmatic trial looking at the primary outcomes of composite of all death and all-cause readmission at 30 days, with the listed secondary outcomes and economic impact assessment in parallel. If we could go to the next slide. And again, so the primary and secondary outcomes are listed there. And we're hoping to enroll 350 complex patients across our deployment sites. So again, I won't spend too much time here, but just wanted to give everyone a fuller picture of the actual evaluation that will be conducted as a part of this research. Okay. So now to provide an overview of what exactly the Medley technology is. So broadly, the Medley program consists of two components. So the Medley service, which encompasses the people, processes, and all of the tools needed to actually operationalize the Medley system. And two, the Medley system itself, which is the core technology. So that would consist of a smartphone app and accompanying clinician dashboard, as well as the inbuilt Medley algorithm and peripheral equipment needed for patients to take their measures. So both of these together aim to support the clinical and self-management of patients living with multiple chronic conditions. The main features of the Medley technology include symptom tracking, so with patients inputting relevant measures for their condition or conditions. Upon inputting their measures, which are run through the in-app Medley algorithm, patients will receive instant and actionable personalized feedback that will instruct them on actions they can take to self-manage their symptoms. So for instance, if someone had heart failure, it would instruct them to, let's say, increase their dose of Lasix, if that would be appropriate. Anything outside of their personalized thresholds would trigger an alert for the nurse. Patients will also be able to review trends and alerts in the app. And then last but not least, the Medley chat or messenger feature will allow for asynchronous communication between the care team and the patient as another communication avenue. Okay, so now that you have an overview of the Medley Smart program, I wanted to also walk you all through how we actually designed and developed the care model to be what it is. So there were 4 phases of our design and development process. So moving from left to right, we first identified what service components actually needed to be included in the smart clinic. Once those were identified, we then developed the smart technology and worked with our hospital sites to understand their unique context in order to actually layer the smart program effectively on top of their existing practices. And once the implementation planning was completed, we then launched the smart clinics, and we're actually currently in this phase 2 of launch today. So diving a little bit deeper into each phase. So the objective of phase 1 service design was to understand the context and needs of each clinic, the providers, and the communities we intended to serve. So this is where we conducted our needs assessment interviews and co-design workshops and engaged with our stakeholders and community members in order to identify the barriers and facilitators to implementation. So some outputs that we developed in conclusion of this phase were site snapshots, which captured key overviews of clinic processes, the existing challenges, patient volumes, things like that. And as a part of that service design process, we also co-defined our intervention components to understand what service components are core to the program and could not be changed across the sites in order to maintain that intervention fidelity versus identifying adaptable components that could be changed across sites. And the illustrations that are depicted here are just samples of patient journey mapping and a site snapshot that were created as a part of that process. And in parallel to the service design phase, we were also designing the Medley Smart technology. And so in this phase, we conducted thorough usability testing with our user groups to understand what the functional requirements would be for the technology. So as you can see on the right here, the different chronic disease modules had different remote management capabilities that were identified and developed as a part of our product co-design, and then again, tested through those usability testing sessions. And just to put an actual visual to the technology, I've just included a sample of what the patient application and clinician dashboard was eventually developed as. So the bottom right here is a screenshot of the homepage that a patient sees when the patient has to complete their chronic disease specific tasks. And the left there, you can see the clinician dashboard where the clinician can view patient alerts through their alert center, see graphical trends of the patient, input their medications, and view their lab results as well. So again, this is just a quick snapshot of the technology. Okay, and then we have our phase 1C where we conducted and completed our implementation planning. So here we worked with our site teams to develop implementation plans and site artifacts that were tailored to the context and needs of each site. So outputs from that were customized implementation plans, determining what level of nurse to hire, and materials like standard operating procedures. As you can see here, I've just included some visual illustrations of the kind of artifacts that were adapted to each site. Okay, and finally, we have our actual launch and deployment. So in October 2022, we began our phased launch across our sites, and our partner sites were chosen specifically due to the different communities that they served, so a range of urban and rural populations. And so the SMART program is currently being trialed in one urban acute ambulatory setting, one rural hospital setting, one community hospital setting, and one outpatient clinic setting. So you can see here the community served by each setting differs, and we were again very intentional during our product and service co-design phases to ensure that we collaborated with community members that were reflective of the communities that we would eventually serve. And so a quick sneak peek into our progress since late last year is that we've had a successful launch across all 4 of our sites, with 25 clinicians actively engaged in referrals and follow-ups for the program across our sites. We have our 4 wonderful smart nurse coordinators, so again, combination of registered nurses and nurse practitioners leading the trial at each site, and are progressing towards our patient target with 50 patients enrolled thus far. And with 50 patients enrolled, I also just wanted to include a patient story from early on in our rollout where a patient was experiencing tachycardia and had subsequently alerted through the Medley system. So our smart nurse was able to follow up with the patient. And as a result of this follow-up, the patient didn't have to return to hospital or be readmitted and were able to receive timely care and self-manage at home. So that was just a very reflective story that was shared to us by one of our nurses and drove home the value of this level of care that's necessary to support our healthcare system and keeping our communities at home instead of in hospital. Okay, and now I will pass it back on to Noor to talk through the Medley Caretown adaptation.
Thank you, Raima. And I think that's a perfect segue into Medley Caretown. So Medley Caretown is really our project that is aimed at developing an equitable model of shared dyadic care to support patients and their caregivers in the co-management of chronic conditions. And this model is really meant to be adaptable across disease states, but is kind of originally being applied to the Medley product. So this project was really born out of a recognition that older adults, and especially those with limited digital literacy skills or English language skills, are often excluded from accessing digital health technologies like Medley. And really during the pandemic, we saw that in order to overcome barriers to accessing the Medley program, patients would actually enroll into the program hand in hand with their family caregivers, which was oftentimes their adult children who were tech savvy and had English language skills. And we recognize that family caregiving is a core value of many diverse communities in Canada. And this experience really helped us recognize an opportunity to formalize the role that family caregivers already play in the care of patients who are living with chronic conditions, specifically within the digital therapeutic space. So this is really where Caretown came from. So we used a design thinking approach to guide this project, which of course was very much an iterative process, even though it's depicted very linearly in this visual. So starting out at the mapping phase, going into sketching and determining what the solution would look like, and then moving into the testing and validation phase, which I'm going to walk through in a little bit more detail. So starting out with the mapping stage, we began by interviewing 25 caregivers of patients who were using Medley at the University Health Network. And in these interviews, we heard some really impactful insights around the caregiving experience. So we heard that there's a lot of unpredictability that comes with living with heart failure and caring for somebody who's living with heart failure, which leads caregivers to feel a lack of control because there is just so much that is unknown and hard to predict. And so because of the challenges that come around caring for someone with heart failure, support-seeking behaviors can really help to mitigate the degree of burden that caregivers experience. So support-seeking can be, leaning on friends and family for emotional support, for support with like caregiving tasks, connecting with healthcare teams and having access to those resources, as well as like financial support to be able to engage in caregiving tasks as well. And kind of along with the unpredictability of heart failure, it really is just so much to know about heart failure. So that can be really overwhelming for caregivers to really manage that high stakes learning curve. And so we also heard about the opportunity and the role that technology plays for these caregivers. So we heard a lot that I think kind of similarly to what Quinn was saying earlier about getting a chocolate every time that that Joe mentions ChatGPT. If I had a chocolate for every time I heard caregivers say that Medley gives them peace of mind, I would probably be eating way too much chocolate. But I think it's really an impactful learning that we heard from these interviews that Medley really does provide a lot of peace of mind to caregivers because it gives them that connection to the healthcare team. They have the comfort of knowing that the patient is being monitored on an ongoing basis and will be followed up with if needed. So really, because of that peace of mind, Medley serves as a key element of the support system for the dyad, so the patient and caregiver pair, because of the supportive features that it offers. And really, technology has the opportunity to empower caregivers and provide them with a better sense of understanding of the patient's heart failure, whether that's educational information about heart failure or about their heart failure kind of journey as well. So I've shared a quote at the bottom here where a caregiver mentions that Medley is pretty much serving the role of being a caregiver for the patient or the caregiver's mother who they are caring for. And so how it can help to alleviate some of the burden of caregiving that is experienced. So based on these interviews, we were able to move into requirements gathering, which really allowed us to move from what we learned in the interviews around caregiving experiences, opportunities, and technology into a list of requirements for the digital solution in the CareTown module itself. And we used various approaches. So identifying long-term goals, whether those were like optimistic future states or pessimistic and realistic perspectives, asking how might we questions to help identify opportunities for improvement towards a future vision, and then mapping the current processes that caregivers go through and how we want that to look like with our solution in place. And so through this whole process, we came up with our 6 core features for the Medley CareTown module, which includes the live reports, care cards, messenger, medical events timeline, medication wallet, and caregiver resources, which I'm going to go through in the next couple of slides. So starting off with our live reports, really this feature addresses the opportunity to provide some data sharing between patients and caregivers. So live reports essentially enables caregivers to access the patient's daily readings that they input into Medley or enter those readings on behalf of patients for patients who might not have the digital or language skills to be able to do that themselves. And so we have a quote from a caregiver here who mentioned that it would be great for them to be able to jump on the app and just have a look and see the patient's symptoms that they recorded on a daily basis and be able to provide them with support that they need based on their symptoms that day. The care cards is really coming out of the opportunity to enhance guidance for the caregiving role. So really connected with that big learning curve that's associated with caregiving. So this provides actionable feedback on how to support the patient in managing their symptoms on a daily basis based on their patient reported outcomes inputted that day. So I think caregivers highlighted that there really is not enough support for them to be able to engage in their role most effectively. They don't have the tips, guides, or supports for caregiving that they would like to see. The messenger feature kind of builds off our existing Medley messenger and integrates caregivers into that circle of care. So this is a feature where patients, caregivers, and clinical care team would be connected and be able to have that asynchronous communication. And hopefully the aim there is to be able to dissolve the disconnect across the circle of care and further provide peace of mind to caregivers in their role. The medication wallet was a really interesting one. I think we heard a lot about medication management being a challenge for caregivers because there's just so much medication involved in the heart failure journey and with many chronic conditions as well. And they definitely would appreciate some improved guidance on how to manage medication and how to support their patients in that. So the medication wallet really provides kind of one repository for all of the medications, to input all of the medications, information on timing, dosage, frequency, what the medication does, and have it all in one place. So this caregiver mentioned that they had a panic and thought, is he taking the wrong pill? Does it get put in incorrectly? So it would be really helpful to have information on what the patient is taking and how much they have to take, what it does, things like that. So that's the aim of this feature. I guess kind of on a similar note, the medical events timeline provides one space for people to input information on what the medical journey has looked like to date. So being able to have a one-stop shop for that medical history so that when you go to appointments and the clinical team is asking, when was their surgery? When did this event happen? They have it all in one place and don't have to stress out about trying to find all of that information. And last but not least is our caregiver resources. We heard time and time again that caregiving is obviously a very big undertaking and one that caregivers are very willing and feel very privileged, I think, in being able to engage in and supporting their loved ones. And at the same time, they could definitely benefit from having additional resources on how to manage that role, how to engage in the self-care that they need to be as effective as possible, and also disease-specific information, because we heard a lot about how the stress of not knowing or not feeling maybe confident in your knowledge about heart failure and the heart failure care journey can actually add to that, to the challenge of caregiving. So making sure that patient or caregivers feel supported with that knowledge is something that they would find really helpful. So those are our 6 features. And really after sketching out those core features, we created a prototype first of the live reports feature. So that's the data sharing feature. And we trialed it out in a 4-week field test with 2 different caregivers who both shared really positive and constructive feedback on the feature. So we then iterated on that feedback and continued to design the full feature set into a prototype, which we recently ran through a set of usability testing sessions with 7 different caregivers. And our team is now really in the validation stage of the project, where we're translating the findings from the usability tests into a second iteration of the design, which we aim to move into development this year. And we're very excited to do that. And after that, we're hoping to be able to launch it within the UHN program for continued testing and evaluation. And I think we've been really encouraged to hear a lot of interest from many different programs on this caregiving module, because there's just such a big need, I think, for being able to integrate caregivers in this formalized way within the digital health space. So we're really excited about the opportunity and the continued project work of our entire team on CareTown. So that is all I wanted to go through for CareTown, and I'm going to pass it back to Raima to talk a little bit more about one last but not least aspect of our work and how we're integrating equity across our portfolios.
Thanks, Noor. I feel like I learned something new about CareTown every time I hear you present. But again, in reflection of our center's efforts to embed equity across our portfolios, I also wanted to share insights that our team learned in working with an Indigenous community partner to implement Medley within an Indigenous community setting. So in recognition that we are an international audience, before I share the background of the project and the lessons learned, I also wanted to state that it's important to recognize that the history of Indigenous peoples in the land we call Canada is complex and marked by colonization, assimilation policies, and systemic injustices. So these factors have had a significant and ongoing impact on Indigenous communities, resulting in challenges such as intergenerational trauma, health disparities, and social inequities. So in acknowledging the challenges that these communities continue to face and experience, I also wanted to highlight the significant ways in which Indigenous peoples demonstrate remarkable resilience, strength, and determination in preserving their culture, language, and way of life. And so this map here is in recognition of the Indigenous populations and territories that exist on the land that our team works in. So the Toronto region, where we sit on the traditional territory of the Mississaugas of the Credit, the Anishinaabeg, the Chippewa, the Haudenosaunee, and the Wendat peoples. Okay. So now just to speak to sort of how this project got started. So in summer of 2021, our center collaborated with a Northern Ontario Indigenous community to support the implementation of Medley in one of our diabetes services called BANT. But essentially our project goals were to improve access to timely, high quality care for patients and family members living in remote and rural communities, being able to support the active involvement of community members in their care through increased partnership, and deliver culturally safe and comprehensive primary health care informed with the Indigenous community rather than by or for. And so similar to our Medley Smart co-design and development process, we went through an extensive service design process with our Indigenous community partner to understand the community context and the strengths to build upon. So we went up on site visits to see and talk with community members. We embarked on cultural safety training and really worked with our partners to design something that was meaningful and of value to this community. So just to share a few of the lessons that we learned in case it's helpful to other researchers working with Indigenous communities or ethnic minority communities. The first insight is to approach the partnership with humility. So as researchers, we must recognize that we are guests in the community and should approach the partnership with a willingness to learn from the community's expertise and knowledge. We are subject matter experts in our fields of research, but they are subject matter experts of their lives and ways of living. The second insight is to ensure appropriate framing of research-related language and content. So it's important to use a strengths-based approach that highlights the community strengths first, rather than focusing solely on needs or deficits. So framing research in this way can help build trust and collaboration with the community in a way that recognizes the shared humanity between both partners. The third insight is to understand and respect the community's consent preferences. So communities may have their own cultural or historical context when it comes to research and may have specific preferences for how consent should be obtained. So it's essential to be aware of and respect these preferences and engage in ongoing communication to ensure that community members feel comfortable and respected in the research process. The fourth lesson is to recognize that knowledge and data are owned by the community, so researchers should not acknowledge and respect the community's ownership of their knowledge, culture, and data. So this means involving the community in decisions about data sharing, dissemination, and utilization, and then working with the community for any research outputs. And the final insight here is to strive for partnering with the community rather than doing research by or for the community. So this means actively involving community members in all stages of the research process, from planning to implementation to dissemination. And it's important to prioritize community priorities and ensure that research aligns with their needs and goals. So I believe that is everything that we wanted to share with the group today. So thank you all for listening and for giving us the opportunity to speak. We've also just included the ICTDH mailing list link here if you'd like to join and be informed of opportunities like this. And then you can also contact myself and Noor at our email addresses with any further questions or considerations that we don't get to after for our discussion. So thank you.
That was super. Thank you very much, Noor and Raima. Really, really interesting, and delighted that it was such a fantastic seminar for our first in the series. I'm happy to ask if there are questions from anybody who's been listening today. Either please speak up or pop something in the chat. I do have a couple of questions myself, but happy for others to go. And I can see your hands up if you'd like to go first.
Oh, thanks, Charlie. Yeah, I basically just first of all to say a really big thank you. That was a really fascinating talk, and you packed so much in there, Noor and Raima. So thank you. That was fantastic. Yeah, I wrote down quite a few questions actually. I was quite interested to know more about the role of patients in the co-design, particularly of the patient-facing app, how that worked. I was also quite intrigued by the Medley Care Town and just actually, and then it brought me on to thinking about it with your last point around working with Indigenous communities, because it was intriguing about the consent model. And I was just even thinking with the Medley Care Town project, how consent works with that, because obviously I guess that the patient is consenting for the caregiver to have full access to their records. So I don't know if I'll pause there. A couple of questions from my perspective.
Thank you, Ange. Great questions there, Raima. I don't know if you want to take the first one around the patient-facing app, and then I can speak to the Care Town part.
Yeah, so tackling the first part of your question there. So in designing both the Medley service and the actual technology or the patient application, we had an extensive co-design process. So we would have interviews and co-design workshops with our community members and patients, as well as their caregivers, to really understand what their needs are for an application or a system like this and be able to work those into our application. So that's just from like a service design aspect. And then once we actually started to develop out the technology, we would conduct thorough usability testing. So with like human factors design experts to actually build out like prototypes of the application, run those through walkthroughs with the patients where we would ask them to sort of like navigate through the app, see how they're using the app, assess it, and then be able to like build upon their feedback to eventually produce like more high fidelity prototypes and then eventually the actual end product. And then just beyond sort of having those direct activities with patients, we also work with a patient and caregiver council as like active members of our research team. So they also inform on sort of like our research activities and project activities and how to create materials or like interview guides that are appropriate as like a patient-facing material.
And to answer your other question about consent in the CareTown module. So definitely an important consideration. And essentially how we're addressing that is through the development of the product itself. We're also working on developing like workflows within the clinical setting that can be applied for implementing the CareTown module. And what that would look like is focused conversations between the nurse coordinator who would be onboarding the patient into Medley, and also having conversations with the caregiver and the patient present to make sure that we are obtaining patients' informed consent about caregivers accessing this information. So having the opportunity to share that data in Medley or to enter that data on behalf of the patient. So that's definitely a core focus of making sure that it's integrated within those workflows. And it's an ongoing process of consent as well. So patients will always have the opportunity to end access for the caregivers if anything were to change. I think it is quite interesting that in our interviews, we definitely heard caregivers and patients mention that for many scenarios, it's not a question of data sharing. It's like, oh, well, obviously I'm going to share my data because I already do. And it's like something that we openly discuss. But of course, it's really important to have that as a focused consideration and an explicit consideration in the work that we do. So I appreciate that question. I also see a question in the chat from Dr. I don't know if I'm pronouncing it correctly, but Cecil Kulu. How are you addressing the digital inclusion piece in the different communities? Any challenges and insights? I think that's an excellent question. And there's really many, many levels of digital inclusion that we're working on addressing. So one of which is, within the Medley model itself, we have a tiered equipment management model where we are able to provide patients with access to the technologies. So the smartphone, blood pressure monitor, and weight scale for those who don't have access to that technology or could benefit from the Bluetooth connections that we're able to provide through our kind of dedicated equipment. So that's one way of addressing the technology access piece. And of course, through the CareTown work that we're doing, I think the way that we're working on addressing digital inclusion is by making sure that we're integrating diverse models of care into self-management through digital technologies. So recognizing the role that caregivers play in supporting patients who might not have the language skills or the digital literacy skills. And I think many of these considerations come from our own experiences. So thinking about our parents and grandparents who probably would not be able to access these technologies on their own, and how we can make sure that we're still facilitating access while not putting the burden on patients to acquire those skills that they might not have the opportunity to be able to, learn the English language or learn how to use technologies if that's not something that's feasible for them. And I see Sabine has her hand up, so just wanted to give you an opportunity to pop in.
Thanks, Noor, and thanks, Raima. So just to echo and just praise for your wonderful presentation. Such a great project. Every time I hear about it, it's sort of, oh God, wish it was my project. So I think I've got loads of questions, but I'll pick two. So maybe one is about, so we're the remote monitoring hub, and Medley is obviously remote monitoring technology. So do you think there are any equity considerations that are specific for remote monitoring technology compared to some of the other digital therapeutics that you work on in the center? So that's one question. Or do you think that it doesn't really matter, the remote monitoring aspect doesn't really matter? And I think the other question is about your evaluation of Medley. So it struck me that you look at effectiveness, and that's obviously a very, that's what we do. But then thinking about equity and all the work that you do around addressing inequity that might come from introducing Medley, have you thought about having any outcomes of equity so that you can measure whether the equity actually improves by using Medley in the way that you intended to use it?
Okay, I can try to answer some elements of that question first, and then Raima, if you wanted to add anything. So for your first question, I think I understand it as whether or not there are different considerations around health equity required for remote patient management versus other kinds of digital therapies or digital technologies. And I think that's a really interesting question, actually, and I have to like reflect on it a little bit. My initial answer would be that probably no, in the sense that I think health equity really just needs to be embedded with like across all kinds of digital technologies. And I guess for each kind of technology, there will be different considerations, but I think the maybe like added impetus for considering health equity for something like a digital therapeutic is really recognizing the fact that a digital therapeutic is providing, like delivering therapy and delivering care to a patient. So we really have to think about making sure that it is equitably accessible to all patients, because when you're widening that digital divide for something like a digital therapeutic, you're really leaving people behind, and they're not able to access that care that other individuals are able to. So that would be my my thoughts on that. Raima, I don't know if you have a different perspective or the same perspective.
No, I agree. I think you across sort of all of the differing digital health interventions, there's all the obvious like equity considerations like health literacy, digital literacy, and things like that, which Noor mentioned should be embedded really across all of these different intervention types and not necessarily like singularly focused on just from remote management.
Yeah, I guess it does. So many remote monitoring interventions do ask maybe just a little bit more of patients and their carers, and it's sort of, you could say, delegate some of the responsibility that used to be with the healthcare system to patients. So I'm just wondering whether there might be, you know, an even bigger impact of things like health literacy and digital literacy, just because you know, you sort of get rid of some of the responsibility and just give it to patients that previously they didn't really have in the same way. But I fully appreciate, I do agree with you that I think across digital health interventions, probably lots of overlap in the equity considerations and the importance of addressing them.
Mm-hmm.
And then just to address the second part of your question around sort of like the equity or like integrating equity evaluation into at least like the Medley Smart evaluation. So as a part of our implementation evaluation, we are going to be assessing or evaluating sort of the barriers and facilitators to implementation. So equity is definitely a component that would be sort of identified and evaluated there through like our post-study interviews and surveys and et cetera.
Thanks very much.
No problem.
Super. Thanks again, everybody, for your questions, and to Noor and Raima for excellent talks. I think we're drawing to the end of the session today. So I just wanted to finish by saying that the seminar next month will be led by the Data Sciences and AI Hub, and it will be hosted by Priyanka Pillai, who is the Hub co-lead in Melbourne. And she will be introducing Dr. Noel Fox, who will talk about his work in data science and AI. And then we have the programme taking shape for June and July as well. We have talks from the Health Policy Implementation Hub, and in July, another one from Remote Monitoring and Virtual Care. So we have an exciting programme of talks coming up. I will make sure the details are circulated through the International Centre mailing list. So if you haven't signed up already, please do so. Thank you for sharing the link to that. And a recording will be made available for everybody who has registered to attend today, and we will circulate that in the coming days. So thank you again, everybody. I don't know if anybody has any final words to say.
I think we just wanted to thank everyone for having us and for your positive feedback on our presentation and excellent questions. I think these are all really important things for us to reflect on. So thank you so much.
Fantastic. Great. Thank you both very much. Nice to see everybody. Bye-bye.
Thank you.
Thank you.
Bye, everyone.